So we have this surgeon at our place, and each time there is a stomach lesion, we get a prone and a supine. This is non-contrast. We clearly see the mass here. Let me just focus on the post-contrast one, and which
Wait, do
is
you do prone and supine because in case it's a diverticulum to see if like air and fluid is changing?
one reason is because the mass can occur anywhere around the stomach, and what if stomach is collapsed? Although we give distension, so we want to see that better. At least the first scan, we want to like delineate where exactly the mass is. Is it like totally endoluminal? Is it like endo extra, or is it just totally extra?
We do that with gastric protocol, having them drink right before they get on the scanner. And some people also give fizzies to get the distension. But I've never even read about people doing the prone and supine except for the diverticulum thing. So I think that's interesting. Do you think it's helpful?
I mean, this is just this one particular surgeon if he sends the patient. Otherwise, we don't do this
Okay.
for any other patients, even if they are gastric cancers. So this is just specific to this particular surgeon at our place.
Okay.
So what do you think this lesion is?
It's like a gastrohepatic node or something. I mean, it doesn't have a broad base of contact with the serosa. To me, it looks more extra gastric, but maybe right there it might be. It's hard to tell.
Yeah, I feel like even though you have great distension here, it's still unclear if this is arising from the wall or just adjacent to it.
Yeah.
But like things I'm thinking about is like just leiomyoma, and then like Nelly said, like a lymph node.
Okay, there I can see that maybe it's coming like it's subserosal maybe because it has more, broad base of contact.
Okay. Yes, just would be my first thought as well. And if I see something like this exophytic from stomach, at least 9 out of 10 times it's going to be GIST. Like 92% is GIST, 5 to 6% is schwannoma, and this turned out to be schwannoma.
Cool.
So that's the
I
reason
think
I'm showing.
Yeah, I think we can't really tell on imaging.
Yeah.
Have to biopsy. But that's good for the patient because one important thing in this case is, do you see how close it is to the GE junction? So our surgeons always want to know that because they are like, it's not super, super close, but that's one of the reasons they want to get the gastric protocol. Because if it's touching the GE junction or involving the GE junction, that's like a much more complicated surgery. And any like gastric tumor involving the GE junction, they often actually have to do a total gastrectomy.
True.
Cool. Good for patient.
But let me know if you.
So this is a youngish female, and she comes with some thickening here, right paravertebral, and if we go further inferiorly, sorry, I don't know why is it loading that slow. So we see this solid cystic lesion. Do you want to describe it any better? Any thoughts what's going on? I can show you the coronal also once I show you the axial.
It's hypoattenuating. It's pretty diffuse. It's displacing the vessels, but they seem to be going through it. I was thinking lymphoma, but lymphoma is usually denser. Like this is very hypodense.
Yeah, it's flashing a lot. So can you just keep it on just a couple image? I have the same thought. It was raising the vessels, but looks too hypodense. So the question is it one mass or is it like lymph node conglomerates? I feel like it's probably going to need a biopsy. One thing that comes to mind, like that I've seen in the mesentery like this, is like a plexiform neurofibroma. Another thing, because you showed that paravertebral soft tissue, like you can get extramedullary hematopoiesis, although it's usually coming out of the bones, not like just retroperitoneal like this.
Sure.
And then necrotic nodes, we think about TB.
Those are excellent thoughts. So I'll just show you the extent of this on axial, and I'll show you the coronal as well.
Wow, this is crazy.
Does the patient have history of like germ cell tumor?
No.
Okay.
That's again an excellent thought. All those points that you raised were like really good differentials, and usually, like the diagnosis is one of what you guys said. Okay, let me show you the lung for the biggest clue.
It's like Lamb or Langerhans cell histiocytosis.
Excellent. Yes, it's lamb, and I was very surprised that I did not know what this entity was, and coming, like being trained in India. I mean, my first thought was definitely as Dr. Shekhar's, was it TB or not? And then secondly, I was thinking in terms of germ cell tumor, but this was lamb as evidence from the lung, and the abdominal findings were also lamb in the abdomen, and it does look like really bad, like solid cystic. So this was also
Wait, so those are
biopsy.
all like sequelae of Lamb? Like all
This
of
is
those?
all lamb, yeah. This is all lamb. It is solid cystic. It can be just cystic. If
Oh.
it is just cystic, then it is like probably easier to identify. Here, it just looked like some solidity, like in terms of enhancement of the septa, and the way it is so lobulated. But the hint, again, like in retrospect, was the vessels were not as bad, like badly compressed or something. So, but again, I know it's like it's
So
difficult
those are
diagnosis.
all lymph nodes, right? I mean, if it's Lamb, it's a lymphatic process?
So lamb actually is the smooth muscles, they hypertrophy and then they just go and clog the lymphatic vessels. So that's how the cysts are formed in the lungs, and probably that's also one of the reasons that all these lymphatic spaces just expand. So that's the
Wow.
pathogenesis. Yeah. So
That's
I was also
incredible.
very surprised.
So cool.
Yeah.
I was just Googling it to
You
see.
had to do cookie jar case for this.
Yeah.
I can ask her. Yeah. I'm sure she would be very much happy because yeah, Dr. Menias loves like all sort of cases. So yeah.
Okay, so I'm looking it up online, and it's usually in
Case
women.
report, definitely case report.
I have seen at least like after I saw this. Okay.
Sorry, Aarti. I'm
Just
just
off the
like
record.
shocked by this case. It needs to be published. Publish this, Yashant.
So okay, just off the record. So one of my exhibits. This
Wait. Should I stop recording?
Yeah, you.
Okay, so I was just Googling, I found the Lamb Foundation. But basically it's much more common in females, and it's usually in the lungs, but also can be like TSC lamb, which is the tuberous sclerosis associated lamb. And that's they also will get angiomyolipomas. They can also get pneumothoraces because of the pulmonary disease. But then it says, although less common, lamb can have lymphatic involvement, blocking lymph flow and causing chylus buildup in the chest, pelvis, and abdomen. So I think, yeah, this must be like basically engorged lymphatics that are obstructed due to the lamb. So it's super, super cool. And then they said treatment is there's no known cure. The drug sirolimus or rapamycin is the first line treatment for patients with LAM with abnormal or rapidly declining lung function. So it's mostly pulmonary stuff, can be associated with TSC, tuberous sclerosis complex, and then occasionally can have like this lymphatic stuff, usually with just chyle, but this one looks like more, yeah, just like lymphatic engorgement. And that makes sense, like the way that the distribution is like along the lymphatics, right?
Yes.
So cool. And yeah, even that like paraspinal stuff is like where the cisterna chyli goes up to become the thoracic duct. So
Yep.
so
Can you
cool.
pause the recording?
Yep.
Ready. This patient came in with abdominal pain. Here's the axial.
I'm seeing stranding around the pancreas and fluid.
Yep.
Ooh. Oh. It looks like I don't know. I'm thinking IgG4. The pancreatic duct looked a little beaded, like the Guadiana sinus, and the overall the parenchyma looks a little swollen. And then we've got that rind. We've got like a capsule around it.
Yeah. Yep. Good.
And then, yeah, that comes back to IgG.
And then, so you can get extra pancreatic manifestations as well.
Yes, and actually I see it along the bile
Yes.
duct.
Yes. What
Yeah,
do
the
you see?
entire bile duct is thickened.
Yeah, perfect. So this was biopsied, proven IgG4. Patient got treated and did really well. Patient got actually, then this is post kind of treatment follow-up imaging um, for like regular annual follow-up. And you can see the bile ducts. There's like it looks like a PSC look, like, but it's all from IgG.
Yeah. And actually the 2 MRCPs ago, what you showed, like the beating of the pancreatic duct was really nice.
Oh, here, this one?
Before that one.
Okay, this one?
Yeah, any of these. Yeah. Yeah, it looks like, yeah, that kind of like, subtly beaded appearance.
Mm-hmm.
And then the same thing with the common bile duct, like that kind of like thickened.
Oh, here.
Yeah, that narrowed,
Here.
thickened, like a cholangio wouldn't do that.
Yeah. And then
So
also there's intrahepatic strictures.
yeah,
Yeah.
IgG4 sclerosing cholangitis.
Yeah.
And when you have the biliary stuff, 92% will have pancreatic involvement. So it's not as common the other way around. Like the pancreas can be involved without the bile ducts, but when you have the biliary stuff, always go look at the pancreas too.
Awesome.
Okay.
This patient came in with history of renal masses. So it's here.
The T2 hyperintensing on the right kidney?
Yes.
Okay. So far, it just looks like it could be a cyst, but it does have a little bit of a capsule.
Mm-hmm.
And maybe some
Okay.
internal complexity. Oh, okay.
Mm.
It's really
Yeah.
dark.
Here's here, let me give the subtractions. It's not really enhancing.
Okay. Give me the delayed. For a second, I
Delayed.
thought
Okay,
it's a
delayed.
calyceal diverticulum because of the
No, okay.
really
Here it is.
T2 darkness.
There's no excretion.
Okay. So not a
so
calyceal tick. So it
nope.
was really T2 dark, non-enhancing.
T2 bright.
Sorry, T2 bright and really T1 dark, like a lot of susceptibility or something. On the pre-contrast, wasn't it really dark? Or oh, an AML.
Yes. Great.
Cute.
And here's the fat stat sequences. Or here's SSFP, and then I have the TSC fat set as well, which shows the same thing.
It's interesting. There's not a lot of enhancement, which we think of AMLs as angio, like a lot of enhancement and washouts.
Maybe this is
mostly
lipo.
Yeah, this is a really fatty AML.
Yes. Yeah.
So it's not a lot of muscle, and that's why it's so T2 bright and not really enhancing.
Yeah, and it sets out. Yeah. Oh, here's the TSC. Yeah.
And then on the out of phase, it had just the full ring of India and Garda effect. So
Yes.
full fat that we confirm here. Cool.
Okay, let me pull it. So this patient had flank pain, and she said that she can feel her kidneys when she's in certain position. So
Her
this
kidneys
was a
do look big. I feel like I
do
see
look big.
the other image. I felt like the kidneys.
Oh, here, this one. Here's
yeah,
the
is that whole thing a kidney?
Right? Yeah, so this is supine, right? So this is supine. Yes, supine. And then here on the left side here's the renal shadow here. Okay. And then this one is standing.
Okay, so it's not as obvious.
Now the kidney's here.
Oh,
This is the liver.
Like a wandering kidney?
Yes. So let me just show you this side by side again. So here, right, there's the renal shadow here, a supine, and then on the upright position, it's here.
Whoa.
Yes. So this is a wandering kidney. Normally if it drops by when we stand, the kidneys normally drop a certain amount. But if it drops by like more than 2 vertebral bodies width, I think then it becomes a wandering kidney. And she can palpate it like when she puts it into it. And it was very positional. Her pain was very positional.
And she's very skinny enough to like be able to palpate this stuff.
Yes.
Yeah.
Yes.
Wow. Cool.
Okay. Let's see. I think that's correct. So this is a patient with history of MEN type 1 syndrome. And patient had a like a pancreatic neuroendocrine tumor and had total like pancreatectomy. On multiple imaging, patient has had this like diffuse gastric wall thickening. And the patient under any thoughts as to what this diffuse gastric wall thickening could be?
I'm thinking Zollinger-Ellison syndrome, if they had a gastronoma, even though they had a total pancreatectomy, you can still have a residual gastronoma and the gastronoma triangle, like duodenal
So
sweep.
here's a dotatate.
The whole stomach seems to be lighting up, but then is there more focal areas like along the cardia?
No, I mean nothing that we can see by MR. And see, here's a little bit of motion, but arterial phase imaging,
And the whole thing
diffusion.
it looks definitely diffusely thick.
Yes, yes.
So the two questions, the two things I'm thinking, like, is it Zollinger-Ellison where you have hypergastrinemia and then just like thickening because of that, or could this be gastric neuroendocrine diffusely?
Good. Yes. So this got biopsied. So and that was it. So
It was gastric neuroendocrine.
type 2 gastric neuroendocrine tumor.
I was gonna say now we have to talk about the 3 types of gastric neuroendocrine.
So it's it can be seen with MEN type 1 syndrome. And they release a lot of gastrin, so patients get hypergastrinemia. And they're small and there are multiple tumors in the stomach. They're indolent, but they can metastasize. And like it's a small minority of patients, and they can get abdominal pain and diarrhea. So the and like I said, the patient did have MEN type 1.
Yeah.
And that's what this was.
Wait, so I'm confused. Is this the same thing as Zollinger-Ellison or?
I don't look it up. Let's look it up.
Yeah, I'm looking it up. So okay, I want to just review again the 3 types of gastric neuroendocrine. First one, which is the most common, is the one that's associated with chronic atrophic gastritis. It's almost like the dip niche of the stomach where like you basically get hyperplasia of all of your neuroendocrine cells. And so they don't resect it. The treatment is basically trying to, let's see, they're usually like multiple, gastrin level is high. And they basically try to treat it by treating the atrophic gastritis. Type 2 is much less common. They're often small and multiple, and they're usually with patients with MEN1. So this is the one you're talking about. Or in people with a tumor of the pancreas or duodenum called a gastronoma. So I think, I guess it's, I guess there's a little bit of overlap there. And then type 3 is when you have like a solitary larger tumor. These are the ones that are more likely to be malignant. Those are the ones we're more likely to see on imaging as a discrete tumor. And yeah, these are kind of more rare, but cool. So yeah, it sounds like yours was not like that there was a gastronoma, but that there was like multiple neuroendocrine tumors throughout the stomach in the setting of MEN1. So they were type 2 gastric neuroendocrine tumors.
Yes.
Cool.
Okay, perfect. Let's do this. So came in with pain, right upper quadrant pain. Here's
The bile ducts look a little funky.
Yes.
I'm wanting an MRI.
Sure.
Let's see. Doesn't look like PSC because it seems like they're all connected. It's not like isolated peripheral ducts. It almost looks like there's stuff inside the ducts. It's like sludge or something inside the ducts, and they're kind of like beaded centrally. They look weird.
Good. So then this is the MRI.
Huh.
Here's the.
There are some filling defects.
Yes.
And there are some strictures. So then it makes me think of RPC, recurrent pyogenic cholangitis.
Where's the diffusion? Here, let me give you the T2 part.
Oh yeah, lots of filling defects. Are they enhancing?
Yes,
Uh-oh. So now I'm
right there.
thinking like IPNB.
Good. Yes. So this patient had spyglass, and that's what it came back as, IPNB. All of
Oh,
this.
cool. Actually, there's,
All of
yeah,
this.
it looks like papillary-ish.
Yep, polypoid soft tissue in the interluminal region of the bile ducts.
Nice.
Yeah.
I gave a gallbladder talk at SABI, and I brought up ICPN,
Yeah.
which is like the IPNB and IPMN of the gallbladder.
Gallbladder. Yeah. I know
And
it because of you. Yeah.
and part of my talk, I like basically walked around SABI and asked everyone if they know what ICPN was, and it was like everyone gave me these like dumbfounded looks, and like
Yeah.
so by the end I was like, we're like, I want you all to chant ICPN. It was kind of fun.
All right, I'm going to share this other screen. Patient came in with pain, right upper quadrant pain. And this was, they did a right upper quadrant ultrasound looking for cholangitis. And this is what it showed. So there's a, okay, so there's a mass, polypoid mass in the gallbladder. So then they got a MRI. And this is what the MRI showed. So a patient has renal failure, and so then has iron deposition in the liver and spleen, and has gallstones, and the mass is there. You can see it better on the axials. But there's more than gallbladder findings. So there's the mass, these are the stones, and then there's all this other stuff.
Whoa, what's all that stuff in the left?
Yeah.
Like, is it in the portal vein or?
Okay, let me give you the
bile
post-con. I think it's bile ducts, but I'll give you the 5 minutes. It's all enhancing. The portal vein is, let's see if we can, it's something like the coronals to look at the portal vein.
Well, just the gallbladder thing looked to me almost like what I was talking about, ICPN. And the bile,
Here, I think the MRCP, here, let me give you the MRCP. So the ducts are gone on the left. So all that T2 intermediate signal is ductal, periductal. And there's lots of biliary ductal dilatation,
Can you show the
segmental.
T2 haste again?
Yes.
Yeah, there's just like a lot of abnormal gray tissue in and around the ducts.
Yep. Yeah. And then
so that I would think this is another IPNB, maybe.
I think, okay, and then actually patient also had extrahepatic findings. So here there's a large abnormal lymph node. There's like hypoenhancing. Let's see if I can find that lymph node here.
Okay, so like malignant transformation of an IPNB?
Yes. So this was,
IPNB.
yep. So then they biopsied the lymph node, and it was adenocarcinoma hepatobiliary origin.
Yeah.
So I think it started probably as that IPNB, or maybe what is it? Intracholecystic mucinous neoplasm.
ICPN for the gallbladder.
Papillary neoplasm. Okay.
You know what's interesting?
Papillary.
This is a great example of like these two being related, the biliary tree and the gallbladder.
Yeah.
And the same things that predispose you to like malignancy in one will predispose you to the other. So, for example, like a risk factor for gallbladder cancer is primary sclerosing cholangitis.
Yeah.
And you think like one of them is like a biliary issue, but like the pathologists, and I think actually like physiologically they're part of the same system. So that like anything that causes dysplasia in one is like affects the other parts too, like almost like a field defect.
Oh, I see. So you think this is all there's not metastasis. It's all just like
Yeah, no, I think
hepatobiliary
it's
manifestation of a common multifocal disease, like urothelial
yes,
carcinoma,
yes,
right? Like urothelial, like you have the upper tracts, but bladders also. I mean, you get it overlap.
yes. That's what I think.
Yeah.
I don't
No,
think that
that makes
gallbladder thing
sense.
is a met.
Yeah, so
I think
you
it's
think it's
like part of
primary.
it. Yeah, that's
Yeah.
cool.
Yeah. Yeah, and then I mean during presentation and subsequent workup, there's also pulmonary nodules and stuff concerning for metastasis.
Mm.
Yeah.
So yeah, we think of like in general with IPNB and ICPN, it's a sea of dysplasia and papillary projections,
Uh-huh.
but they don't necessarily have adenocarcinoma. They have like a lower rate compared to just like de novo cholangio. But when you do like this one, it has had the malignant transformation, you have the cholangio. So now like we're in the adenocarcinoma realm, then you can get mets. But otherwise, in general, they have a better prognosis because they don't
Awesome.
necessarily have adenocarcinoma.
Like IPNB though, I think, I mean the difference, I know you mentioned the IPNB and IPNM, but IPNB, like I think the quoted is like 70% will harbor you know, or they'll become it's pre-malignant, right? They will become cholangio. And so even like IPMNs we survey, but IPNB, I think they're treated, like surgically treated because of that
Yes.
risk
Yeah.
of
They're all surgically treated if possible. But the overall prognosis is better because like it's not like 100% adenocarcinoma, right? Like even if
right.
it was 70%, that's still better. And
Yeah.
then like even if it's a lot of soft tissue, a lot of it can just be like low, moderate, or high grade dysplasia, not necessarily like invasive adenocarcinoma.
Oh, I see.
And
Yeah.
same
Yeah.
thing with the gallbladder. ICPN has like about a 50% malignancy rate.
Oh, I see.
So it's not
Yeah,
good,
it's
but
pretty
it's
high.
bad.
It's pretty high. I mean, in contrast to IPMNs, right? I mean, IPM is like
Yes,
20,
IPMN's
so
like
much, much
much,
lower.
much
So
lower.
that's why they can be surveyed.
Yep.
Yeah. Cool.